this is going to be very interesting and fun because it's a clinical presentation, and we actually have 6, I think, people that are ready to give some examples of special moments with clients, but I'm sure we have lots of new people as well as older members that are clinicians. And as you are listening to some of the stories, hopefully you will come have a thought of your own, and we would love to have you jump in at the end. So let me introduce our director of this particular presentation. David Bender received his Ph.D. from the University of Tennessee in clinical psychology in 1981. He spent his extensive career doing a wide variety of clinical work. And during his time at Blount Memorial Hospital, he saw inpatients for alcohol and drug abuse, eating disorders, and serious psychiatric problems in psychiatric units. He also did clinical supervision, forensic evaluations, individual and family therapy. He's going to be leading our group of experienced clinicians in describing a variety of what we call special moments with clients, moments that were especially important to these clinicians in their clinical work, during or after therapy. We'll be leaving some time at the end, so I hope you will think about jumping in, and remember to put a cue in the chat box to me only, and I will call on you, and I will give special preference to our newbies. So David.
Thank you, Dr. Bergner. Let me begin with an apology. In my writing up the program, I indicated this session was going to be a panel discussion. Well, it's not going to be a panel discussion. It's going to be a series of presentations, or serial presentations, if you will. And we were introduced to a blitz earlier today, and I think you're going to have a therapeutic blitz, because we have 60 minutes and 6 people, each of whom is going to present some special moment with a connection to an aspect of descriptive psychology. So I get the privilege of beginning. Mary Roberts will follow me, Sonia Holt, then Fernand Lubbegin, Ray Bergner, and Dr. Lori Bergner, if there's time left. And let's hope we have some. So let me get right to it. Early in my public career, I worked at a community mental health center. And one of my tasks there, among many, was to assess candidates for law enforcement. The state of Tennessee had early on adopted a set of requirements, actually a set of double negative kind of requirements, so that police officers had to be certified by someone in the psychological or psychiatric field. Psychiatrists didn't want to touch it at all. So it was generally left to those of us in mental health centers to do the work. I had a young man come in, was in his early 20s, and all around went through my battery of tests. They ended up spending about a half a day with me, with the interview, all the formal assessment stuff that I did with him, and looked like a pretty good candidate, all in all. But for those of you familiar with the MMPI, he had an elevation on scale 2 and scale 7, psychasthenia and depression, usually the kind of thing that you see in somebody with a mild depression, what we used to call a dysthymic disorder. It may not be called that anymore. Things change, as we found out earlier. But in the course of discussion with him, I noticed that he was quite the critic. And I had some time toward the end of my available time with him. And let's see if I can bring up what I presented to him. We had about 10 or 12 minutes, something like that. I said, look, I noticed on the MMPI that your mood state was a little down, and that I noticed during the time that we spoke, you tended to be a bit hard on yourself. And he said, well, yeah, I am. He agreed with that. He turns out, to my mind anyway, to have been a little bit of a perfectionist. So I said, let me show you something. And I drew up this diagram on a little whiteboard that I kept handy by my desk chair. And earlier in this conference, you heard from Dr. Cantor, Dr. Charlie Cantor, about a work by Garfinkel, a sociologist, who wrote about successful degradation ceremonies. This particular piece that I'm giving you is from Clinical Topics by Peter Ossorio, and in a minute I'll show you the reference on that. But this is a very small version of a two-person degradation ceremony where one person is the denouncer witness, and then you've got somebody being denounced who's the perpetrator. And I said to the young man, I said, you know, this is pretty clear when you've got two people involved. You've got one who's standing up and saying, hey, look, something's not right here. They condemn, they criticize, they find fault with, and then you've got the guy who did wrong, who's the victim. And it's pretty clear who's one up and who's one down as well. The denouncer there is in good standing, in the right, righteous, in charge, one up, powerful, and the guy on the other side, well, he's put down, he's degraded, criticized, in the wrong. He's less than the other guy. He's powerless here, as opposed to powerful. And I said, there's pretty clear difference. And he said, yeah. I said, now imagine if A is criticizing A. And he gives me this look. And I said, I think you do this. I think your mood stuff is here where you're the one catching it, but you're always busy over here being the critic. He said, yeah, I never thought of it that way. I ushered him out the door. He was, in my estimation, very qualified, particularly for the county that I was working in. And you're all probably wondering, so where's the special moment? Some number of weeks later, as I was walking a client out toward the waiting room, this fellow sitting in a chair, waiting for me. He's got a big grin on his face. He says, Doc, you got a minute? And it turns out I had a minute. Took him back to the office and he said, I just wanted to thank you for giving me that little diagram. He says, it's made a world of difference. I mean, I'm happier than I ever thought I'd be. And all I had to do was be a little kinder to myself and lighten up. And turns out what he did was he used the criticism paradigm and criticized his own criticism, put it into proper perspective, and gained quite a bit as a result of that. For me, that was a very special moment. A little bit of work, a little simple something like this made a big difference for this fellow in his life. Here's the references. The seminar on clinical topics from Dr. Ossorio will give you more details of what I've begun to describe today. And there's the Garfinkel reference, 1956. I think it's only a 4 or 5 page article, something like that. So it's a quick and easy read. Dr. Bergner, Dr. Ray Bergner, has also done extensive work on destructive self-criticism. There's a reference for him. And he and our beloved deceased member, Jim Holmes, did the self-concept change notion, also worth looking at. If any of you want to do a screenshot of this, I'll leave it up for just a second. And otherwise, I will ask Mary Roberts if she's ready to take a turn. I will exit my screen share and we will move this blitz right along. How do I get out of here? Oh, I want to stop share.
There you go.
Yeah, I got almost enough practice, didn't I?
Good job. All right.
Mary, are you with us?
I'm with you. I also wanted to, for people who've resonated with David's example, remind them of Ray's book, Dr. Bergner's book on pathological self-criticism, because it's right in the same ballpark.
Is your partner in crime ready and available here? Do you know? Fernand?
Absolutely.
Yeah.
Okay.
You go.
All right. Good morning, everyone. So there were a number of us last night who got together and kind of did some impromptu preparation for today. And out of that discussion, I was inspired to choose not so much a particular moment, but to choose a case that I think compellingly illustrates the therapeutic power of acting on those three essential policies and the therapeutic power of acting on those policies per se. And I find it compelling because I'm going to present a case that's been the most challenging of my entire career. So I'll try to do this in quickly, but hopefully also thoroughly enough for it to make some sense and given the 5 minutes or so. So she's a long-term client. Again, like I said, the longest term client I've had. So I've been seeing her for over 20 years. The first 7 of which was at Kaiser Permanente, where I was a staff psychologist, and then subsequent years in my private practice. During the first 5 to 6 years, her primary concerns were depression, anxiety, and grief from the loss of her mother. In fact, that was the reason why her primary care physician had referred her particularly to me, because she was really struggling with at that point, anticipating the loss of her mother. When I reflected to her that, I use these words, something doesn't quite add up, because, and this was, probably about 4 to 6 years after starting treatment. And I did so because her condition, in terms of her anxiety and depression, hadn't improved significantly despite years of treatment. She revealed to me that she has dissociative identity disorder. So after my initial surprise, I just kind of started to think about, well, how does all that make sense? In brief, she has an extensive, a severe trauma history, starting at 4 years old when her mother's male romantic partner began physically, emotionally, and sexually abusing her. And that this chronic abuse persisted for at least, from this one perpetrator, persisted for at least 6 more years. As if that wasn't horrible enough, she was sexually assaulted several more times through adolescence and adulthood by other men. The last incident occurred, at least to the best of my knowledge, or to the extent she's divulged, occurred in her late 20s. She is now a 67-year-old retired social worker. Okay. So just by a quick way of review, the 3 essential policies: treat your client as a person, be on your client's side, and show the client, show your client the sense that she makes. Starting with treating your client as a person. This is especially pertinent to her because she experienced being treated as an object. These are, this is her own word. She was treated as an object vis-a-vis being sexually abused and being told that she was quote unquote trash and quote unquote worthless by her initial perpetrator. So rather than referring to alters or personalities or other kind of psychological terms commonly associated with talking about and working with people who have dissociative identity disorder, we use the term states of being, states of being. This perspective and term has the connotation, conveys the connotation that conveys that she is a coherent person who experiences different states rather than being a severely pathological diagnosis. Another way in which she's found particularly helpful that relates to treating her as a person, my authenticity also effectively conveys treating her as a person. In other words, or more specifically, I treat her in an I-thou manner rather than in an I-it manner. And one of the ways in which she especially appreciates it is through my use of humor. It actually serves two purposes, and I hadn't kind of thought this through. In a moment, it was rather spontaneous. One is that, particularly when she's anxious, when I use humor appropriately, it rather effectively and quickly alleviates some of her anxiety. And one of the ways in which she experiences anxiety is that she holds her breath, and that has a lot of kind of related roots in her history. My point being that when you're laughing, it's very difficult to hold your breath. And so she finds immediate, at least some degree, significant degree of relief in the anxiety when we laugh together. And just as an example, I say to her that she's particularly special because she's one of the few people who can actually change her minds. Okay. Boom. Okay. All right. Moving on to being on your client's side. Given her history of being severely abused, combined with having a neglectful mother who struggled with alcoholism, and not so much an absent father, but she didn't spend much time with her father because they were divorced. She has ascribed to me the status of being her protector, among other statuses. And of course, this occurred only after years of testing me in order to determine whether she regarded me as trustworthy. So as a particular example, we created a ritual of starting sessions by co-creating what she refers to, what she describes as the bubble of safety, which essentially is her metaphorical way of reestablishing our therapeutic alliance. And given her severe history, referring to the maxim, people take the world as they found it to be, her world is fundamentally dangerous and unpredictable. And so she's needed to reestablish in a very formalized way the therapeutic alliance. And so we engage in this ritual of bubble of safety. And fortunately, I've been able to maintain and honor and meet her ascribed status to me of being her protector. So, lastly, showing the sense that she makes. Interestingly, she refers to the way in which she visualizes, conceptualizes her dissociative identity disorder is through this what she calls a construct. And it's very creative. In brief, she imagines very vividly a home where what she calls her helpers have their own rooms. And this construct or this home is where her helpers live. She describes, in her words, giving away her traumatic events to her helpers. And that's kind of her way of conceptualizing or understanding her dissociative identity disorder. And she often refers to her as being crazy or sick or being severely disturbed by having DID. And I kind of re-describe what she did in a very simple way, which is that as a 4 or 5-year-old, what was occurring to her was unthinkable. And therefore, her construct was simply her creative and way, and I think I would argue effective way, of making the unthinkable thinkable. So, thank you.
Thank you, sir. Well done.
Thank you.
Is Dr. Ray Bergner available? Dr. Ray?
I got to unmute here. Yeah. Okay. Am I on?
You're on, sir.
Okay. So special moments. So I could call this, put this under the heading of implementing a descriptively based strategy, or also under the category of therapist loses it to a small degree. So the descriptive idea here, it's somewhat, we have an unsavory description of this strategy here in descriptive. It's called spitting in the client's beer. The idea being maybe they can go on drinking it, but it ain't going to taste the same. In more refined terms, it's providing a redescription. Let me just switch to something else here. Okay. Providing a redescription of something the client is doing, such that if they accept this new description, under this new description, they're given strong reason to no longer do what they're doing. All right. So the client was a woman, I'd say late 20s. This was many years ago. Lori and I were back in, working back in the Washington, D.C. area. We're talking about late, mid 70s or so, but I'll never forget this incident. So she's like late 20s. She came in and she was depressed. It was about a specific situation, which I actually don't recall. I have a hunch of what, but basically I'm not sure what it was, but it was a specific kind of thing. So she said, I'm depressed about this. And one of the things she would do is in her depression, she would go to her husband every night and basically say, you know, I feel so depressed. Can we talk about it? And he would say, okay, honey. And she would talk to him for, 2 or 3 hours. She also had a good friend who was also a neighbor. She would go to the neighbor during the day and she'd say, oh, I'm so depressed. Can you talk to me? And the friend would say, sure. And she would wind up talking to the neighbor for a couple hours. And so this would occur, like almost daily, with the husband, with the friend, just many iterations of this. Okay. So we talked about the problem, and as I said, I don't remember quite what it was, but I remember after a few sessions, it was one session where I had the sense of, okay, today we resolved the problem. I think we solved it. I think next week she's going to come back in a really better way. So I remember sometimes I'd have this sense about a session. I'd say, that's going to make a difference. Okay. So that's the sense I had. So she comes back next week and she says, I'm so depressed. There's no change. And I'm a little surprised, but okay. So go over what we've been talking about. And again, I'm feeling like this ought to make a difference. It comes back again. I'm so depressed. This is not making a difference at all. Okay, and one more iteration of that comes back. Da, 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 da. So along about the third time, I just had this sense like there's something wrong here. This doesn't feel somehow honest. It feels like, I don't know, well, feels like a bit of a con. And anyway, so I say to her, I say, you know what? I actually don't think you're depressed anymore. I think this depression is like a claim ticket. And you can take it to your husband every night and you can say, honey, I'm so depressed. Here, redeem this ticket for 3 hours of discussion. And then the next day you can go to your neighbor and you can give her a claim ticket. So Sonia, some tickets involved here. And you can say to her, here's my ticket. This entitles me to 3 hours of discussion about my depression. Okay. And I think that's what you're doing now. Okay. So she leaves and she comes back the next week and she says, I feel much, much better. I'm not depressed anymore. I hated you last week. I hated you. But she says, but what you did was brilliant. And I'm thinking, what did I do? All I remember is I kind of lost it. Anyway, it turns out, she says, I went out after the session. I went out to the parking lot. I sat on the curb and I screamed at you. I ranted and raved for an hour, and my husband kept trying to get me into the car. He said, honey, please, let's go home. You're making a spectacle. She said, I sat there for an hour just raging. Finally, I got in the car, went home. But next day, I don't know what the time, I wasn't depressed anymore. Okay. So she didn't report any further depression after that. So I guess the way I always thought about it was how I described it. I re-described it in such a way that, and she accepted, she hated me and she hated the redescription, but she accepted it. And when she saw it that way, she couldn't keep doing it. Okay. So that's my story of a, not exactly heartwarming, but a session that made a quite dramatic difference.
Well, that's delightful. I mean, you, I think it's delightful. And you appreciated the significance of what she was doing. You went right to that. And obviously she had to, like Sonia, figure out a different way to participate, right?
Yeah.
So there you go.
Yeah.
Good for you. That's delightful. Lori, we got plenty of time for you, I think, huh?
Oh, yeah, but we want to leave time for other people because I know we have other clinicians. But
Okay.
I'll try to be fast. I have two, actually. One is so simple, but it made a huge impression on me. I ran into a salesman one day in a store. He said, oh, I saw you a while ago. I actually didn't remember him. I think I'd seen him once or twice several years before. I didn't even remember him. And I said, well, was it, how was it? He said, well, it was really helpful. I was in an awful marriage and my wife did not treat me well. And, but I wasn't leaving her. And you said to me, it doesn't have to be this way. It can be better than this, as simple as that. And he said, I always remembered that. And eventually I got out of my marriage and I'm remarried very happily. And I just always remembered that you said that. It's such a simple thing, but it's I guess I think of it as eventually increasing behavior potential because it changed his status, that I believed that he could have a better relationship, that it was a matter of this particular relationship and this particular wife. And what it really did was, at the time I thought of it as giving people hope that life can be better. And I think it is that, but there are some, status dynamic things you can talk about. But I think it was the first time I said to myself, I'm really changing people's lives. And it was wonderful for me. I mean, it really was. It made me, I don't know, it increased my status in how I thought about myself as a therapist. So now I'll tell you a little bit longer story, but I'll try to keep it really short. This is a woman that is very special that I've seen for a very long time, a number of years, and which is very unusual for me. But she has struggled with depression and anxiety for all that time, coming from an absolutely awful childhood with a mother who I believe was probably psychotic and would treat her as invisible, literally not speaking or looking at her for weeks at an end, and for no good reason. And so she took that, as we all do our childhoods, in terms of what we expect of the world. We take the world to be as we have found it to be, and has struggled with wanting the world to be a better place, wanting relationships to be better, etc. And we had talked a lot. She was always unhappy with everything that happened between people, very, very, very sensitive. And so anytime she felt like people let her down tremendously all the time, including her 2 grown children and friends, etc. And she was always saying, if only they had said this, or if only they had said that, or if only they had written a thank you note, or if only, if only, if only. And we talked about it a lot over the years. But last year, I also was inspired by Walter's presentation and the idea of insisting that the world be better than it was, be different than it was, be the way I want it to be. And I thought about this client right away, and I thought, that is absolutely so relevant to what is going on here. So I couldn't wait to see her again when I came back. And she came in, and I said to her, you know, you are treating the world like you are the director of a play. And everybody that you have in your life has a part in this play, in your mind, and you have a script. And when they don't go along with this script, you feel very let down. But you are insisting that they are in your play with your script. And they are not. They are persons, they are people. And they are in their own world, their own play. They're not in yours. And she was just shocked. She said, well, I didn't know I did that. And I said, well, yes, you do. So she goes home. She asked her husband, do I do that? And he said, all the time you're saying this. And you know, I still see her, and she is so special. And she came back, and recently, in fact, we talked about this as a turning point for her depression. And what she's been able to do, she would just dread meetings with her children. She loved them, but it was always a disappointment. She's been able to have get-togethers with her children without being devastated by what didn't happen in those meetings. And one of the other things that we talk about a lot is giving value in order to get value. And instead of looking at what she was not getting out of those meetings, she was looking at what was there. And one of the things we talked about is sometimes it's not a matter of having a good time. It's what the meaning is about a time. It may not be a great time with your kids, but it's meaningful. It's meaningful that they want to get together and that you want to get together, and you have a bond that's there, even if it isn't fun. And not all families are fun. In fact, I think lots of families are not much fun, but that doesn't mean they're meaningful. So anyway, thank you, Walter, for your idea. And I must say that my client used it so well, and it's just been wonderful to see that things have changed.